Good evening, Mark Sakel, and I'll be talking to you about the risk adjustment programs that we have for this year for our risk patients. We've collected cardiology and pulmonology together because your organs are in the same general vicinity and deal with similar patients. This is the entryway or the gateway check for your incentive bonus. To get a bonus for this year, you have to listen to this 22-minute spiel by myself. Many of you actually perform this quite well. Some of the newer cardiologists, I think, could use a little training. And certainly pulmonology could use a little training as well. So nothing personal, but we want to do as well as we can on this stuff. So go over definitions. The term that we are looking for is risk adjustment factor, and that's an estimate of the population's complexity, by which we mean the expected cost to the payer, by which we mean Medicare. Medicare derives the RAF score from a variety of conditions that are deemed high risk or high value or costly, and they must be properly documented. What does properly mean? This is very important. They have to be done with diagnosis, assessment, and plan, not jump together in some intelligent piece of verbiage, but all analyzed out. And our payer calculation is done all RAFs of all the patients, including the demographic factors, adjusted usually downward to an average score of 1.0. And then after, the payment to physicians, IPAs, physician groups, is markedly affected by this RAF score. This graph is from the New England Journal last year, and if you look at the dashed line, think of it as a pre- and post-review of Medicare visits. The dashed line is basically a unitary line, that if you documented 1.0 and an experienced coder looked at your note, it was still 1.0. You'll notice what this actually did was the solid line. So in St. Paul, you see for a RAF of about 0.83, for about 5, they documented 0.93. That's an increase of almost 0.1, which is worth millions of dollars to a 10,000 group IPA. In Texas, on the other hand, you can see that they go lower by a factor of about 0.1 to 0.2 because they just don't pay as much attention to this, and they are losing scads of money. Would Meritage fit? Well, we're getting closer to the dashed line, but traditionally we have been the solid line. And the states that do very well with this tend to be in the Rust Belt states and Northwest. And you can see that in Minnesota and Michigan, they code very well, and they code 10 to 15% higher than the average. And in California, which is kind of, where we are kind of a lavender, we're about -5% to 2% lower. So there may be a 20% differential that we get compared to the physicians in St. Paul for the exact same work, all sorts of coding intensity, not medical care intensity. This is important not just because it's a money game, which it is, to be frank, but also because it levels the playing field by quantitating the riskiness of my population of patients to another geriatricians or one area to another area. This helps do comparative research. It helps identify patients who might benefit from management based upon, let's say, a RAF of 1.4 or higher. And basically, it refines the amount of money the feds have to pay after the fact. So with underwriting in the old days, you would look at the demographics of a group, the insurance company would set a rate. Now what they do is, about 2 years later, they pay us for the work we did 2 years prior based on the intensity of our coding. We did at Meritage for the physician group. We started the program in December 2015 when we said, OMG, we lost $2.5 million on 5,000 patients. Then we started improving our RAF, and in December in 2016, we broke even on this population in the outpatient setting. In 2017, We think we're going to make about $2 million, and probably will be much better on the inpatient side as well, but we won't know that to 2019 for sure. And we think we can hit 1.0, which is a bit of a stretch for Marin County, maybe not for Sonoma, since our patients tend to be a little healthier than average. The name of the game is to look at the cylinder and to capture all the conditions that make up the cylinder. The dark blue is the documented risk, and the light blue is the risk that exists but not documented. It's like when a tree falls in a forest, et cetera, et cetera. So we want to all hear that tree and put it into the medical record and get recognized for the care we actually provide. So of a woman with systolic heart failure, depression, and functional quadriplegia due to RA. And you see, if you just look at her demographic risk factor, she's only a 0.8. But if we add the HCC conditions, and this is not all she has, we left out RA, for example, she'll have a normalized RAF score of 2.2. In other words, the group will get $9,000 rather than about $3,000 for caring for this person, for the same work we already do. And the intent of Meritage is to turn about 8% of that back into incentive bonuses for all of our physicians. All right, switch gears here for a minute to review how you document to make your charts audit-proof. You, especially in cardiology, are absolutely superb. Some of you have a little bit to learn based upon what I've seen, but the key to this is there are three components: the diagnosis, the logic or status, and then the plan. And these diagnoses should be clear to someone who is with a high school education who wants to find fault with our charts. So they have to be analyzed into diagnostic or diagnoses with an assessment of either why you came to the diagnosis if it's new, or the current status of the diagnosis if it's old, and then your plan. So let's look at a couple of examples. Chronic systolic heart failure. Let's say it's a new diagnosis. Perhaps you made the diagnosis because the echo you performed was 40%, and the patient's currently euvolemic. And the plan is what you're going to do about it. Continue the current dose of furosemide, carvedilol, and add ACE inhibitor. You add those drugs all the time, but it has to be clear within the rubric, within the diagnosis of systolic heart failure. So how an existing diagnosis? First thing I want to tell you is try to refine the existing diagnosis to an HCC diagnosis. And the perfect example is if someone was had a fibrillation last year, but now you did a zero patch and they're always in fibrillation, you change the diagnosis of paroxysmal to persistent atrial fibrillation. If you're on Allscripts, you do that by right-clicking and then hitting Refine ICD Diagnosis. The advantage of that is all your verbiage will be maintained from your previous diagnoses. Your status evaluative patient, recent ZEO patch shows conversion to persistent fibrillation, and then your plan, refer to EP if that's what you want to do. And this will also allow you to diagnose now secondary hypercoagulable state. And most of the cardiologists know that quite well. There are some diseases from the coding guide that we distribute and are happy to redistribute to you again. Notice hypertensive heart disease. I think that means, here. That means, I think it means hypertension with LVH, but it means whatever the cardiologist thinks it means. So having hypertension and LVH separately isn't as good as having hypertensive heart disease. Atherosclerosis of native coronary arteries with angina. Note that atherosclerotic heart disease alone is not HCC adjusted, but if it has angina, it is adjusted. Note angina means that you're treating the patient for angina or potential angina. So when you give a nitroglycerin prescription, someone has angina, even if they have angina. If that's not clear, call me or email me. Then you'll see a lot of codes, of course, ST elevation MI, and those are basically inpatient codes, and you probably know better than me. They probably can be coded for about 2 weeks in the outpatient setting. Okay. We have some pulmonary diseases here, pulmonary embolism, that's pretty obvious, and acute core pulmonality would be an inpatient diagnosis. When someone's outpatient and you keep them on Coumadin or Xarelto for more than 6 months, they probably have chronic thromboembolic disease. And that's an ACC code, but I don't have it on the list right now. And the common COPD, emphysema. I see emphysema a lot on CTs done for other reason, where the radiology will mention emphysema. Emphysema is an anatomic diagnosis, so I will code it when I see it on the CT scan, or it exists when the pulmonologist says it exists for whatever reason. So these things that are chronic diseases should be coded once a year in your notes. Just complete things out. Just to let you know, you will be seeing depressed patients. Why else would they become, if not depressed from their heart and lung disease? And just to let you know that if you find yourself a depressed person who doesn't have a primary care physician or alcoholic, that it's technical difficulty with some equipment, so I'm hoping you can hear me. Just to round things out, I'll let you know that major depression is an HCC code. Depression itself is not. The most depression is major depression, and that's been a simple interview with a Q9 or the fact that you've chosen to treat someone with an antidepressant. And here's just for your information. Similarly, we'll all see alcoholics or people on opioids. You be the primary person seeing them. So sometimes they'll see you more than they will see us primary care physicians. And don't forget to diagnose alcohol dependence in remission if someone has stopped drinking. And if someone's on Norcos 3 or 4 days forever, they are typically drug dependent, whether they like to see that in writing or not. And they're worth a lot in terms of HCCs. Going to help the doctors, specialists, and primaries to master these complexities of patient care and documentation. For primaries, we have the risk assessment identification program where we do pre-reviews, send them potential codes, and then check to see that they're appropriately carried. Very time sensitive. It's been very successful. We have a work-at-home program where we will send out an advanced practice clinician to actually do these visits at home. That's quite successful, but a lot of docs don't like us going out there. I would, because it's the easiest way to do things. And then specialist, this is your education 26 minutes, and this will count as 1 point for your bonus incentive plan. Last year was about $800. You, especially if you're new and haven't been to my other trainings, can have a one-on-one inpatient session with myself or Dr. Forster. And need any more coding guides, let me or Jess know. Here's a study for you to meditate on. It's a happy, still alive 86-year-old man who's had a ICD placed. He's treated complete heart block and tachyarrhythmias, by which I mean at least atrial fibrillation. He's swollen, he has orthopnea, his EF is 45%, he's a long smoker, and he's chronically oxygen dependent and depressed. So here are his medicines, what ACs are likely, and just for fun, I'll be quiet for 10 seconds. Okay, that's thinking. We want to be collected for major depressive disorder. Why? Because he has a THQ of 10 and he's on Zoloft. Atrial fibrillation persistent. I'm kind of assuming that, but it's really important when someone has a pacemaker and is pacemaker dependent that you diagnose that as cardiologist. I can't tell as a primary care physician and read your notes, knowing whether the underlying rhythm is chronic or paroxysmal fibrillation. But that's really important for you to do. Similarly, if it's chronic fibrillation, you can put in secondary hypercoagulable state. He may have some acute on chronic systolic heart failure. He has COPD. He has chronic respiratory failure, oxygen dependent, pulmonary hypertension, and something occurred to me. Oh, he probably has sick sinus syndrome. And you can bet because not only does he have a pacemaker, but he requires a beta blocker. That's something, again, that the primary care doc might not figure out. So if you're treating somebody for arrhythmias with a beta blocker, you can still code sick sinus. If they're on a pacemaker and don't need a beta blocker, you have cured the disorder. So all in all, the guy has a RAF well over 2, probably, and that's worth about $8,000 to the medical group. We turn most of that back over to all the docs. Bothering this, besides the financial implications, while we're doing the work, we should get paid. This will allow us to continue accepting Medicare patients. And I think it's important that you all sort of practice getting to the new conversion, getting to the new documentation requirements. In case you get audited, you'll thank me in retrospect someday if you get audited. We find the RAF scores are useful to identify which patients need complex care management or case management to keep them out of the hospital as much as possible or seek support services. And every now and then you'll find something that you hadn't thought before. So it's a new trick, and most of us listening to this are old dogs. And I think that it's not very easy to master. I think some of you who are gamesmanship players have done extraordinarily well. Some of you are resisting it still. I encourage you all to do your best in trying to code appropriately so we can do as well as we can, maintain risk patients in Medicare. And by the way, now about 80% of Meritage patients are risk, which includes WHA, Blue Shield, a couple others I can't remember off the top of my head. So this is the way of the future. I thank you for your attention.